Human life rests on an incredibly precise ratio of water to sodium. Shift that balance even slightly, and the biological systems that keep us alive begin to fail in a predictable cascade. To understand how those failures happen, we first have to measure the baseline. In a healthy adult, total body water makes up roughly 55 to 60. Sodium is almost exclusively restricted to the outside of the cells in the extracellular fluid, while potassium is trapped inside the cells in the intracellular fluid. This deliberate imbalance in ion concentration creates a powerful osmotic pressure gradient. It acts as a structural force that literally prevents these fluid compartments from collapsing in on themselves. Knowing exactly where these specific fluids and ions belong is the mandatory baseline. Only with this map can we start to diagnose what happens when the architecture breaks down. Water does not move randomly through the body. Its transit across biological membranes is strictly enforced by localized physical laws. At the capillary wall, fluid exchange obeys Starling's law, a tug-of-war between hydrostatic pressure pushing water out and oncotic pressure pulling it in. At the cell membrane, exchange is governed by osmosis. Water passively shifts from a low toward a higher osmolar concentration, reaching equilibrium. This movement is driven by effective osmolality. It relies specifically on non-diffusible substances, particles that cannot easily cross the cell membrane, which forces the water to move instead. In practice, effective osmolality equals 2 times natremia plus glycemia. Natremia is doubled because sodium is the primary driver of osmotic pressure. Remember, osmolality is driven by small solutes at the cell membrane, while oncotic pressure relies on large proteins at the capillary wall. In short, Starling's law manages the physical volume inside the body's pipes, while osmosis dictates the actual hydration level inside the cells themselves. To maintain the normal cellular volume that osmosis dictates, the body operates as a closed hydraulic system. It must perfectly match daily water inputs with daily outputs. It accomplishes this water control through 2 mechanisms: the conscious sensation of thirst, which drives us to increase intake, and antidiuretic hormone, or ADH, which signals the kidneys to reduce water loss. Because sodium directly controls osmolality, the body must strictly regulate sodium excretion, a process called natriuresis, alongside water. Natriuresis is managed by 2 opposing hormonal regulators, aldosterone and atrial natriuretic factor, or ANF. This table shows their interaction. Aldosterone is a sodium saver. During hyponatremia, it promotes kidney sodium reabsorption, decreasing natriuresis. Conversely, triggered by hypernatremia or volume excess, ANF forces sodium excretion. Remember the mnemonic: thirst drinks in, ADH saves water out. Extracellular fluid disorders come down entirely to issues of volume. They occur when a patient has either too much or too little total fluid occupying the plasma and tissue spaces. ECF hyperhydration is an abnormal increase in that volume. Clinically, this excess fluid pools in the interstitial sector, leading to generalized edema, causing physical tissue swelling and dangerous systemic hypertension. Conversely, ECF dehydration is a net loss of both sodium and water, causing the physical volume to drop, resulting in structural collapse symptoms like severe hypotension, lingering skin folds, and rapid weight loss. Looking at this table reveals a counterintuitive fact. In purely extracellular disorders, natremia remains entirely normal. The sodium level stays stable because the sodium pool and water volume expand or contract proportionally together. Trap: never confuse volume overload symptoms with cellular dehydration. If a patient presents with massive physical volume changes, but their sodium blood labs come back normal, you can isolate the failure entirely to the extracellular compartment. Intracellular fluid disorders operate entirely differently. Instead of total body volume changes, these disorders involve water shifting aggressively across the membrane, moving directly in or out of the cells themselves. These shifts are driven by changes in plasma osmolality, which show up on a lab report as abnormal sodium levels, or dysnatremia. When plasma becomes hyperosmolar, hypernatremia, above 145 millimoles per liter, water is forcefully sucked out to dilute the surrounding plasma, causing cells to physically shrink. If the plasma is hypoosmolar, the gradient reverses. As shown here, water rushes in, causing cells to dangerously swell. The clinical shortcut is simple. High sodium pulls water out, shrinking the cell, Low sodium lets water in, causing it to swell. Because brain cells are trapped inside the rigid skull, rapid cellular size changes manifest clinically as intense neurological symptoms like confusion, seizures, and coma. An abnormal sodium lab always points to an intracellular hydration crisis. It requires immediate, precisely calculated correction to protect the patient's brain function. While isolating extracellular and intracellular disorders makes them easier to study, real-world pathology is rarely that clean. Patients frequently present with global disorders, where both compartments fail simultaneously. Global hyperhydration involves total water and sodium retention across all tissues. Global dehydration is the massive loss of total body water alongside a severe sodium deficit. This master comparison map cross-references the features of extracellular, intracellular, and global disorders. Notice how sodium and osmolality remain stable in ECF volume disorders, but swing wildly in intracellular and global conditions. Because symptoms overlap, precise labs are the only way to diagnose global disorders. Managing this system falls to the kidney, the ultimate regulator of water and sodium. The golden rule: sodium balance dictates extracellular volume, while osmolality controls cell volume. Master this single rule, and you have the biological foundation required to untangle any hydration disorder a patient might present with.